We have developed an investigator-initiated trial of Nivolumab and Axitinib at the standard doses in patients with anti-PD-1 refractory metastatic melanoma. The rationale for this trial is really based on our own in-house preclinical and translational data. We had previously shown that high melanoma tumor cell oxidative metabolism, and this is coming from patient samples, is associated with dysfunctional and exhausted tumor infiltrating lymphocytes, and the tumor microenvironment itself is hypoxic. And so that allowed us to link intratumoral hypoxia to high oxidative metabolism of tumor cells. In other words, we're looking at hypoxia in the tumor microenvironment as a surrogate of dysregulated tumor cell metabolism. And based on our data and data of many others, we started to think about mechanisms by which we might remodel tumor vasculature to make T cells better able to do what they're supposed to be doing in the first place and fight the melanoma tumor. So with that in mind, we developed this phase 2 trial, investigator-initiated. It was duly funded by BMS and Pfizer, and we enrolled 31 patients, all of whom had progressed on anti-PD-1 refractory melanoma. The patient population itself was really quite difficult to treat, if you will. What I mean by that, first and foremost, is all were metastatic, all had received anti-PD-1. Over half, to be specific, 52% had received anti-PD-1 and anti-CTLA-4 concurrently. 68% had received prior adjuvant therapy. And the thing I'd really like to highlight is that almost half of the cohort had mucosal or acral melanoma, and these are very well understood to be difficult to treat subtypes. We had 7 patients with acral, 7 patients with mucosal, and 15 patients with cutaneous melanoma. 2 had unknown primary. So in other words, 14% or 14 patients, or just under half of the cohort, had acral or mucosal. The majority of patients had LDH at least 1.5 times above the upper limit of normal. This is well understood to be a poor prognostic biomarker in melanoma. We also had just under a third who had liver mets, about 20% who had brain metastasis, and the median prior lines of therapy was 3. In my world, as a melanoma oncologist, that's a high number of prior lines of therapy. And the range was as high as 7. And we had over 1/3 of the cohort, 35% of patients, who had progressed on 4 or more prior lines of therapy. So you can appreciate that the population we were dealing with was really quite difficult and a poor prognostic population. So a couple of things I'll point out about the trial. Patients started on Nivolumab and Axitinib at the standard doses concurrently at day 0, and they continued treatment for up to 2 years. There were no breaks in the Axitinib. It was continuous 5 milligrams BID. In terms of the translational effort of the study, which I think is the most interesting, certainly, we utilized pimonidazole, which is an in vivo hypoxia tracer, and patients take an oral dose at 500 milligrams per meter squared, 16 to 24 hours before each biopsy. So patients took a dose of pimo before their initial biopsy, which was pre-treatment, and then at week 12 on treatment. And there was an optional biopsy at the time of progression. And we ended up having paired samples for about 14 patients out of the cohort. And the data that I shared at SMR was from a cohort of 9 whose correlative analyses have been completed. I'll come back to that, but in terms of the efficacy, we found that the disease control rate, meaning the number of patients who had stable disease as their best response, was 42%. The patients who had a more clinically significant response, i.e. a partial response, the ORR rate was 10%. And of the patients with a partial response, we had 1 patient with acral, 1 patient with mucosal, 1 patient with cutaneous. Of the 13 patients with disease control, we had 4 with acral melanoma, 2 with mucosal melanoma, and 4 with cutaneous. And so this suggests to us that this combination can yield clinical benefit, which in this population, I would argue, encompass a stable disease in all subtypes, including acral and mucosal, which we know are so difficult to get a response or even stability from. Now, the median duration of response for the 3 patients who had a partial response was 8 months, and the upper boundary for that has not been reached. We had a patient who completed his 2 years, had a partial response, has not had any subsequent therapy. The median duration of disease control was 3 months for those who had stable disease. There was one patient that I think is very interesting as an anecdote who had had progressive disease, and his subtype was mucosal. He had a very deep systemic partial response. He had a single brain met, new brain met on trial, and so he came off in August 2023. Of course, was classified as PD because he had a new brain met, and went on to have gamma knife radiosurgery to that brain met. He never had any subsequent therapy, and he actually remains on surveillance, maintaining his response well over a year out at this point. We found that the median progression-free survival was 3 months, the median overall survival was 10 months, and we then did some exploratory sub-analyses that I think are of interest given this complex patient population. When we asked ourselves where patients who had received prior Ipi-Nivo, and recall it was 52% who had, were patients who had received prior Ipi-Nivo more or less likely to have clinical benefit, we found that patients with prior Ipi-Nivo were less likely to have an objective response or a partial response. So we had seen one patient with prior Ipi-Nivo have a partial response versus the two others who had a PR had not had prior Ipi-Nivo. Interestingly, however, prior Ipi-Nivo did not preclude disease stability. And of the 16 patients who had had prior Ipi-Nivo, we saw almost half, 44%, have stable disease. I also want to point out some of the subset analyses that we did in terms of the histologic subtype. We found that patients with acral and mucosal melanoma each had a high likelihood of having clinical benefit, here defined as stable disease. 71% of patients with acral melanoma and 43% of patients with mucosal melanoma had disease control. We also did a lot of interesting correlative analyses that I shared at SMR. We had done some immunofluorescence staining looking at pimonidazole, which I'll remind you is an in vivo hypoxia tracer, SOX10, and the overlap of SOX10 positive and pimonidazole positive areas. And we saw very clearly that patients who had stable disease had a reduction in intratumoral hypoxia at week 12 compared to baseline. We saw this in 2 cutaneous patients in whom we had paired samples. We saw a significant reduction in each of the mucosal and acral patients on this trial who had a partial response. And the data are, I should say, the immunofluorescence slides are really quite striking. You see pimonidazole at baseline, and then we really see none at week 12. We found the opposite, which is very much in line with our hypothesis, in patients who had progression of disease as their best response. We saw intratumoral hypoxia as measured by pimonidazole go up at the week 12 time point compared to baseline. When we looked at the overall cohort, not stratifying by response, we found that hypoxia at week 12 is decreased compared to at baseline. And interestingly, we found that CD8 T cell infiltration in the tumor measured by immunofluorescence goes up at week 12 compared to baseline. We've also started to generate some of the intratumoral flow cytometry data. And what we found, again, these are in paired samples, baseline and week 12. And this is bulk flow. So obviously, we're getting a much more mixed picture, if you will, compared to looking at the immunofluorescence data. But what we see is that in patients who have a response, and here response is measured as clinical benefit or stable disease, partial response, these are counted as a response. In patients who have a response, compared to those who don't have a response, looking at baseline tumor versus week 12 tumor, we see a reduction in LAG3 expression, and we see an increase in TNF alpha and interferon gamma and CD8 T cells as measured by flow cytometry. Interestingly, we don't see any significant changes in CD8 T cell numbers. And so all of this data together suggests to us that we're seeing decreased exhaustion and more activation of CD8 T cells at week 12 compared to at baseline, meaning on treatment compared to not on combination treatment of Nivolumab and Axitinib. And as I previously showed you, we didn't see any significant change in the number of CD8 T cells overall, but we do see increased CD8 T cell infiltration, suggesting to us that there's favorable modulation of the TME as we had set out to do. So we are continuing some of the correlative work. We have some vector panels. We showed a little bit of that at SMR, and certainly we will share more of that in the publication, which we're in the process of preparing. And so all told, our conclusions from this investigator-initiated trial of Nivolumab and Axitinib in patients with anti-PD-1 refractory melanoma is that we see disease control in this population, most notably in patients with acral and mucosal, who had disease control rates of 73% and 41% respectively. And I'll remind you, this was a heavily pretreated population, median 3 lines of prior therapy, high LDH in the vast majority, liver and brain mets present as well in a significant proportion of the population. So in terms of toxicity, we shared at SMR the most common treatment-related adverse events that we had seen with the combination of Nivolumab and Axitinib. We did not see any unexpected toxicities. The toxicity that we observed was very much in line with the mechanism of action of each of these drugs. And the most common all-grade toxicities were fatigue, hyponatremia, transaminitis, hypertension, diarrhea, oral pain, and mucositis. Grade 3 and 4 toxicities, fortunately, were uncommon. The most common grade 3-4 toxicity was fatigue, occurring in 13%, followed by transaminitis and hypertension. We did not observe any grade 3-4 mucositis, and we did not see any grade 5 toxicities. One thing that's interesting, and we had anticipated this might happen, is that 9 patients, 29%, required dose reduction of Axitinib. We did not find that dose reduction was associated with significant differences in progression-free, overall survival, or best radiographic response.